Today, we're talking about sleep studies and sleep evaluation with Dr. Avinesh Bhar. He's a board-certified sleep physician and the founder of Sleep, an online sleep medicine practice. If you're a doctor who wants to up-level your sleep medicine knowledge, go ahead and subscribe to this channel to join the community and keep learning about practical clinical sleep medicine. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine, and every video is eligible for CME credits. And before we jump into the interview, I'd like to invite you to get my free sleep mini course for outpatient doctors. It's filled with practical tips to use in your clinical practice. So the link is in the video description below, and you can also grab the free course at IntraBalance.com/doctors. So Dr. Avinesh, thank you so much for joining me today. I'm really looking forward to our discussion about sleep.
Thanks for having me. Appreciate it.
So we were having a really nice chat just before we started recording about the importance of sleep medicine for overall health, and the importance of sharing this knowledge with other clinicians who maybe haven't done a sleep fellowship or haven't done advanced training in sleep medicine. Because so much of us get so little training in sleep during medical school and residency. So I'm just curious to hear more about why you became a sleep doctor. What drew you to this field?
I don't know whether I was drawn in versus I was kind of pushed into it because I was at the end of my PGY 6, which is my 6th year of postgraduate training in pulmonary and critical care. I had enough time already, but I've always had this sense of curiosity, and I wasn't ready to grow up yet and get a big boy job. And so I spoke to my mentor, and we were kind of balancing out between sleep and interventional pulmonology. And the point that he made still stuck in my head. He said, if you do a sleep fellowship, you will be a better doctor to your patients, because our patients with pulmonary issues, breathlessness, and so on, but frequently many of them also had sleep issues. And that really stuck with me, and that's been my goal, is to always be a better physician. And that's how I decided to do a fellowship and take an extra year, took another pay cut, and I can say it was 100% worth it, because I'm loving sleep. I'm loving talking about sleep with my patients, and it definitely has made me a much better resource to my patients as well.
Definitely. I think we share that passion for sleep, because it truly is the fundamental of health. It's the foundation of health. And without good sleep, it's hard to do all the other things in life that keep us healthy, like to exercise and to eat well, but it also has real physiological effects. Could you share a little bit more about why clinicians should be thinking about sleep as a root cause in their patients, even though sometimes patients don't have obvious sleep symptoms? But it's still something we should be thinking about. So can you share more about that?
Yeah, and I use this term about the obvious patients who are like overweight, falling asleep in your waiting room, loud snorers. These are what I call 5-year-old sleep apnea patients. A 5-year-old can diagnose them. It's really the patients all in between. The large majority of they're not so silent because they do snore, but to a lesser extent. And so that's not what draws them into or getting an evaluation or referral. But I think the pattern to see is when you start seeing patients dealing with multiple medical problems, and that could be blood pressure, diabetes, blood pressure, hypertension, mental health issues, whether it's anxiety. The one that I'm curious about is not so much bipolar, but patients who have anxiety and depression at the same time. And I think frequently we don't realize the connection that sleep has that keeps them on this seesaw of feeling depressed and low and so on, and they get the checkbox of depression, and then they also, hey doc, I'm also anxious, and then they get an anti-anxiety prescription, but no one puts 2 and 2 together and figure out why. What's keeping these two things together? Why does someone have hypothyroidism and then also is getting testosterone shots? Why are you on B12 shots? Or because you complain of fatigue, or if you're having chronic pain, why is your pain not addressed? Is that something that's affecting that? So I think as clinicians, we like solving problems. However, we do one thing really poorly, is ask the question why. Why is this human being sitting in front of me having the worst luck? Why is Miss Smith having 4 or 5 different medical problems? And now she has CKD as well. I mean, if someone fed you a story and told you all these unlikely scenarios that one human being could walk through life and live a somewhat average life and then accrue all these medical conditions, you'll say that's fantasy. That's a science fiction. but they walk in through our doors every day and we never ask the question, why? What am I missing? And frequently you will find that sleep is not even addressed or even a question is brought up. A simple question to ask that patients start to look at me like I'm an idiot is like, how do you feel when you wake up? And they're like, what do you mean how I feel? How else do you feel? And I know I already have them, because at that point, they're not waking up feeling great. Because if you were feeling great, that wouldn't be a question that you would even think to respond to that way. So a lot of times, like you talked about how much sleep affects us. The analogy I use is, I say every morning you start off your day, it's like 100-meter dash. Boom, the gun goes off. Everyone's out of the blocks. Everyone's excited, high-fiving, cheering, and so on, because they had great sleep. But you find yourself, if you're not sleeping well, whether it's restless legs, whether it's insomnia, whether it's sleep apnea, you're like starting behind 10 meters behind everyone else, going, you know what, you guys go ahead. I've got my own little lane. I'll stick to it, because they're in survival mode. When you're exhausted and you wake up tired, you're in survival mode. You're all about getting from point A to point B, check off that to-do list, and then get back home so that you can rest for a while and then maybe get sleep. And then the whole cycle, it's like the worst version of Groundhog's Day. It starts all over again. But as human beings, we're very resilient. A change with sleep happens over many, many months to years. So our expectation of sleep changes, how we should feel when we wake up, the energy levels that we used to miss about, bouncing out of bed, completely gets slowly altered with our perception of what's expected. And so most patients after many years don't realize that they're sleeping poorly, and no one actually asks them, how do you sleep? Do you sleep well? Do you wake up refreshed? And we should be asking these questions more often and trying to figure out, is there a better way to treat this? Because I think a lot of times we assume insomnia, the terms that patients use, oh, I'm not sleeping well, I've got insomnia. As providers, it's a knee-jerk reaction that we provide a Band-Aid. Here's an Ambien, here's a Trazodone, here's something else to help sedate you. This is fine short-term when it comes to like things like acute insomnia, but when it's long-term beyond that, you always have to ask the question, why? So I'll pause here, because as you can tell, I can keep waxing lyrical about this.
No, thank you, Dr. Avi. And that was so much good information. And I love that analogy of the 100-meter dash in the morning, and people with sleep issues who are kind of lagging behind because they are in survival mode. And I think that's a really important point for clinicians to recognize, that patients are suffering when we don't identify and treat their sleep issues, right? And patients don't know how to describe it, right? They just know that I'm not sleeping well, or they might not even think they're not sleeping well. They might just say, I'm tired all the time. And
they deal with it because they don't want to bring up, if they have blood pressure issues and diabetes, they don't want to bring up another diagnosis. And if they have a 9-minute visit with their primary care doctor or provider, how are they going to at least bring that up, or at least have a meaningful conversation about it? They can't. So even when they do, it gets kind of patted away, and they're left kind of fending for themselves. So it's going to be caffeine in the mornings, or alcohol at night, or something over the counter that they continue to use, because they use that as a patchwork for that pesky time that they have to sleep. And let me just deal with that, because I've got so much more to deal with during the day, but not realizing how much of that 8 hours contributes to your meaningful day that you're going to have, whether you're a caregiver, whether you're a breadwinner, whether you're just a human being trying to get through the day. That sleep is critical. And I think we're not seeing as much of an understanding of that from a provider side, let alone the patient side.
I think that's exactly right. And so many people, like you said, are just living with bad sleep, with poor quality sleep. And it's so normalized, I think, in our culture as well, to be tired all the time. And so people
it's also sometimes someone uses it as a sort of a medal. Like, yeah. I only got 5 hours of sleep. I'm surviving on 5 or 6 hours of sleep. Oh, I have a routine in the morning, Dr. Bhar. I will wake up and I will shower and I will do this. And I'm like, waking up shouldn't be that complicated. Neither should falling asleep be complicated. You don't need to be having 3 different kind of teas. You don't need to be having candles that, with lavender oil. You don't need to be taking, it's a natural process that someone who gives a rat's ass should be able to talk with you and figure out. And I think that's what we're missing, is that a lot of times, like we discussed before the session, was the number of sleep doctors available, let alone providers outside the sleep field who should have the basic understanding of quick fix. And I'll give you one that always kind of is in my opinion, I think such a simple fix. And most people, we hear this from patients. Oh, I go to bed at 9 o'clock because I'm trying to get my 8 hours of sleep. That's not how it works. And that's why you end up staying in bed, and then the angst towards sleep increases. Now, what started off the process could be an acute period where you weren't sleeping well for whatever reason, whether it was pain or health issues, stress in life, exams, finances, whatever you want to deal with. But when you start getting poor sleep, you start trying to go to sleep earlier because you're waking up multiple times. When in actual fact, the real magic is actually waking up at the same time every morning, because the predictability of your sleep-wake cycle really gets determined. It's so much easier to wake yourself up at the same time than force yourself to sleep unnaturally at a certain time. It is that forcing yourself asleep at a natural time that requires sedation, sedatives, and so on to kind of knock you out. So we need to figure that out. So one of the basic concepts that a lot of patients I talk about is, listen, I say, don't worry and don't sleep in. It's going to be painful for you the first few days. And if you are prone to mania or manic episodes and so on, definitely from a psychiatry perspective, you want to be very, very cautious about doing this. However, most patients will benefit from knowing the fact that if they wake, and we all have about a 16 to 18 hour window to stay awake. If you like waking up at 7 o'clock, set 7 o'clock in stone, and then you will calculate forward and you will see 16 hours falls at 11 o'clock. And that builds some you're not getting into bed at 9:30 and then tossing and turning for an hour and a half. Because what that does is actually increase your likelihood to stay awake rather than mellow you out and go to sleep. So these simple tools that I think a lot of physicians could benefit and providers could benefit from. And I wish the information was out there. So I thank you for having this YouTube channel to disseminate this information.
Yes, no, thank you for sharing that. I think that's a really simple but important point with just going to bed a little bit later, waking up at a consistent time every morning. These simple things can have a profound impact on somebody's experience of sleep and their energy levels, regulating their circadian rhythm, sleep drive, and all of that stuff. So, okay, so for the clinician who's listening to this, like maybe they are the PCP who only has 5 to 10 minutes in a visit, or maybe they're a psychiatrist who has to focus on, anxiety and depression. They don't have a ton of time to talk about sleep. What are some high-yield questions that a clinician should be asking their patient? You mentioned, asking, how do you feel in the morning when you wake up? Mm-hmm. What else do you recommend clinicians ask?
So I think it's always a conversation starter. The two questions that I would propose is, are you waking up refreshed? And do you sleep well? And I think those are very open-ended questions, because that starts off the process of, let's talk a little bit more about sleep. And a lot of times we want a checklist that we can get. None of the checklists, I'll tell you, this works. Epworth Sleepiness Score, pretty much useless, unless, of course, you wanted to prove a point. If you come in and a patient fills it out, the stop bang score as well, great for pre-op populations, not good for general clinic population, because you don't have those patients. That's a lot of the studies and our understanding currently, and the wide-ranging understanding for sleep or sleep apnea, really comes with this poster child of someone obese falling asleep and loud snorers. And really, we're seeing everyone, and I'm sure your practice as well, you'll see people that you never assumed have sleep apnea. I'll tell you this, I have sleep apnea. And I was diagnosed just a few months ago because I wasn't and called me a hypocrite, because she knew that I was waking up not as refreshed, and she heard me snore and she said, you should get tested. And I was like, no, it can't be like that. She's like, you're such a hypocrite. You tell patients this opposite thing all the time. I'm like, yeah, you're right. And I tested and I was positive, and it makes sense now. And I started on a CPAP, and that's been great. But if I didn't have that acute insight into how I feel when I wake up, it would not have come to this. And I think a lot of patients are left not being treated because we are all into our little mindset of, it has to be, oh, Miss Smith, you can't have sleep apnea. You hardly even snore. But is someone actually listening to your breathing all night long? And the answer is probably not. And when your partner goes to bed, they're great at sleeping, they're falling asleep, they may only hear you try to breathe for maybe 10 seconds, 10 minutes. And so even snoring is such a poor indicator of sleep apnea, because women don't snore loudly. Women tend to huff and puff or purr. I mean, you have different terms, and you'll get this. I'm sure you see this in your practice. Whenever you ask a woman this, she will qualify how bad a snoring is and really downplay it most of the time, unless, of course, it's really bad. And then on the men's side, they're just like, yeah, they just told me I snore loudly. So, there's a lot of these things where in our heads, we don't want to be associated with certain disease process because in someone's head, it's like it's someone who's in poor health, who was overweight, but I'm not overweight. I can't have that. That's wrong. And even look in the back of your throat, that's not a great indicator either. Because you have no idea when someone's looking at you talking right now and opening their mouth, whether that's the same muscle tone that's going to exist when they lay back and in REM sleep. So there's so much nuances. So I think asking those questions, do you sleep well? Do you wake up refreshed? I think are two conversation starters. And then from there, looking at the medical history, if someone has atrial fibrillation, they all should be screened. If you're thinking someone has high blood pressure and you're putting them on a second blood pressure medication, you should start thinking, because that's one of the most common causes of secondary hypertension. I know we love our pheochromocytoma diagnosis, but let's give it a break. We don't have that many walking around. There's way more with sleep apnea. If someone has poorly controlled blood sugars and you're trying it, the thing is this, as providers, we have to understand that no human being wants to be unhealthy. They don't want to be in poor health. It's not everyone has, these are not Munchausen type syndromes where, someone has, they don't want to be ill. They don't want to do that. So you have to figure out why someone's blood sugar, despite what they're telling you they're trying to do, or someone wanting to quit cigarettes or wanting to be healthier, they all want to do that. Don't forget, we all human beings, we're all about the same. We all have our desires, our needs, what satisfied, our wants. We all want the same thing. We want good health. We want good connection with people. And if someone's not able to provide themselves with good health and they're somewhat capable of it, meaning that they're not debilitated, and they can't care for themselves, you have to figure out if sleep is an issue, because that frequently is that 800-pound invincible-ish gorilla in the room that we're not even addressing yet. So I'll pause. Sorry.
No, amazing. So much good information there. And, I think, what you were saying about sleep apnea, not always showing up in that, very obvious way that the 5-year-old can diagnose, right? So not everyone with sleep apnea has a big, thick neck or loud snoring. And I see this all the time in my practice, especially with women coming in with treatment-resistant depression or a diagnosis of fibromyalgia, chronic fatigue syndrome, when actually, there's sleep apnea that was undiagnosed. And they're often surprised. They're like, I'm a petite woman, I'm not overweight. My husband has sleep apnea. He snores really loudly. I don't have it. Right. But yeah, exactly. So we should be on the lookout for these things because, again, patients are suffering and we need to be thinking outside the box to see what's really going on.
Or we need to put sleep in that same box.
Let's put sleep into the box. Yeah.
Because, I think a lot of someone walks in and says fatigue, we're doing the CBC, we're checking the chemistries, we're checking a B12 level, we give them a shot, we check a TSH, and we don't, and the patients like they feel better. And we like to think that we helped them, but we actually didn't, because we just put a Band-Aid on the problem and then hope things work out. And then you see them back, and patients want to please you as well. They want to feel like they want to tell you the right thing. So you're like, how do you feel? I feel better. Oh, good. Done my part. In actual fact, no, you haven't really scratched the surface yet. So. Yeah,
absolutely. So, okay. So let's say you are a PCP or a psychiatrist, and now you think, okay, there's something going on with this patient's sleep. What's their next step? Should they refer them to sleep medicine, or should they do some workup on their own first? What do you recommend?
Good question. So I think a lot of times on the sleep side of things, we would love more people to take ownership and be able to do this on their own and initiate the sleep test. However, where I find there is a problem is a lot of the sleep tests, especially the home sleep tests, are actually validated on the populations that are higher risk. And so we have this huge number of patients that end up being falsely negative or are told, oh, you have mild sleep apnea, you don't need treatment. And I'm just like, for me, it's just like the worst. It's like saying, oh, you have a diagnosis of heart disease, but it's mild. Are you kidding me? Like, I don't categorize my CHF as mild, moderate, severe. I have CHF and I need to get treatment. I have sleep apnea and I need to get treatment. I think a lot of them misunderstand that when you have this AHI, the AHI has very little correlation to how you feel as a human being. You can have a super high AHI and the only reason you're there is because you're forced at gunpoint by your spouse who's tired of hearing you snore. And they have minimal symptoms. I mean, you can prod and poke them and they're telling you nothing. They're fine. But then I have patients who are barely mild and sometimes even barely negative, And then I have to retest them and they come back positive. And that's when we start treatment. They're like, oh my God, it changed everything. And I think that's where I'm concerned, is that when you put the test in the hands of someone who doesn't understand the 20% like false negative rate with home sleep test, they use that or they use the mild result and say, oh, I don't think this could be causing your level of exhaustion, Ms. Smith. Oh, it couldn't be causing your atrial fibrillation. It's not severe enough. I think they're mistaking the severity of the test result with the indication of a treatment. And you and I know that's not true. So, while I'm happy that people take on the ownership of this, I always frequently say, I tell a primary care doctor, I say, just send me the test results and let me speak to the patient. If you want to order the test first, great. But you would be misdiagnosing someone and saying that they may not need it, or you may not, if they test mild and they realize that they could actually get an oral appliance versus a CPAP, that's what we can talk to them about as well. The appropriateness of mild, moderate, severe, that does really help us decide or determine what treatment pathway is best for the patient or treatment options available. And so I do think, from a primary care perspective, if you're a specialist, if you're a psychiatrist and you want to order the test, fine, that's great. Do that, get the ball rolling, but have a sleep physician see the patient and determine whether the test is valid and whether that needs treatment or whether it needs further testing. And that's what we do in our practice as well. One thing we're trying to do is cut down the amount of waiting that the patient has to go through to be seen. Because don't forget, from a person who's not in healthcare, let alone not in sleep, they're not going to be really high in the priority of, hey, I have a cardiologist, I have a nephrologist, I have an endocrinologist, I have a dentist. Oh, and then maybe I'll see the sleep doctor. He's like sixth on my list or fourth on my list of priorities. And it's not something that's bugging me because I'm a resilient human being. I will do what I need to do to survive and get through the day. So sleep tends to get ignored the further out you schedule that appointment. So we're trying to break that and try to ensure that we get patients seen as quick as possible. So patients get referred to us. We immediately see whether they have test results or not. And if not, then we start talking to them about what your sleep symptoms are, what your medical baggage looks like, and how they connect. Because I think that's one of the things that impresses upon them is like, holy cow, you're telling me my reflux at night, my grinding, this headaches, the atrial fibrillation, the atypical chest pain, my pulmonary hypertension, I can keep going, anxiety, my depression, all of this is related. I was like, yes and yes. And I tell them, I say, I feel like a snake oil salesman because I'm going, look at this, we can do and all so much more. And I have to stop myself and clarify with them. I say, this is a theory. Once we treat you, you will see the benefit, and that's what we're going to do. So, right from that, I think I want more practitioners to recognize sleep, but we are available as well if you need us, because we're there to help. We're trying to make sure we cut down the time span. So it takes weeks to get them evaluated, tested, and then treatment disposition. We follow them up long-term as well. We're not just in episodic care that you come to us, we'll get your sleep test, we'll write your prescription for CPAP, and good luck, Ms. Smith. We don't believe a medical practice should behave that way. And what we do is we see patients as many times as they want to see us. We also see them for the annual visits as well. So once we get them on a good cadence, we'll see them annually. If they need an oral appliance, we'll refer them to an oral appliance. So that's why it's a discussion to have with the patient to figure out, I'll show them what a CPAP mask looks like. I was like, you have an idea that a CPAP mask looks like it's going to suck off your face. But in actual fact, these are what masks nowadays look like. I'll show them an oral appliance, because you have to make sure that the patient's in on it as well, that they understand their options and they're going, okay, because if they're going to sleep with it, they better like it. And they better feel like not only it fits well and it does well, but they actually wake up feeling great. At that point, the pain of going through a CPAP setup or the pain of getting the oral appliance fitted and titrated becomes less of a pain point, because the value they're getting from it is so much, especially they see the value of that. That's what allows them to go through the process. And if they get their sleep issues treated, we're already seeing data now about how cost of care, how the acuity of their health conditions all improve right the year after. So we're already seeing the data now. And I wish, that's why the good work that you're doing gets out there to more folks to kind of recognize this.
Yes, no, thank you. That's really compelling, to see the improvements and the outcomes that happen after treatment. And I think, again, to recap, you've made so many good points there. So one thing for PCP psychiatrists or any clinician who's working with patients to recognize is that home sleep tests do have a high rate of false negatives. So just because it comes back as negative, it doesn't mean that the patient doesn't have sleep apnea or they don't have sleep apnea that needs to be treated. Sleep apnea can fluctuate from night to night. So what you
Mhm.
capture on one night might change the next night. So this is why multi-night testing, as you do in your practice, can be
Mhm.
very beneficial. It's not like oh, I did my hemoglobin A1C blood test 2 years ago and it was fine, so I'm good, right? And that's what we see in sleep medicine. Oh, my AHI was fine. I did it 5 years
It
ago.
was mild. They told me I didn't need treatment. I'm like, but now you weigh 30 pounds more, and I don't think the sleep apnea was addressed then. You may not have gained that weight as well if you were sleeping better as well. And that's,
Yeah, exactly. And it's this vicious cycle. So, okay, so then let's say you're a clinician, you're working with a patient and you're talking to them about, I think we should get you tested for sleep apnea. This might be contributing to some of your other struggles. And the patient says, "Oh no, I don't want to wear that mask. I don't want to go through that whole testing." How should a clinician approach that resistance with a patient?
ooh, good point. And I see that a lot, but I'm a lot more comfortable handling that question. But I can see why that would be where it's a kind of a showstopper at that point. I would suggest, and again, I tell patients that's like, just the iPhone was 10 years ago. It's a different beast now. The machines on CPAPs are so much more intuitive. They're literally silent. I have patients who actually have to take the mask off to feel the air pressure to say that it's on. Otherwise, these machines have been geared from a consumer's perspective so much better that the patient, it's silent and it's so much more intuitive to our needs, whether you're on your side or on your back, deep sleep, light sleep. All of these, the airway stays open and it's so much more comfortable. They have all these comfort features now. The masks have changed tremendously. When I was in training, I mean, like it was just like, oh no, they didn't like this full face mask. Let's try the next full face mask. Holy crap, that didn't work. Miss Smith, you're out of luck. We'll have to try again something else. And so it's a matter of exploring. I always encourage patients. I said the first mask is important, but not critical. It's a journey. You're going to be like Goldilocks. You'll find one you like, but you may not love it. And then you'll switch it out and then you'll switch it out and you just keep trying. And then we will get you the right one. But I think from a mask perspective, the device setting perspective, it's completely changed. And then also understanding that there are other treatment options available out there beyond just CPAP, which our appliance has been great. And I think, nowadays with the data coming out as well on potentially medical management of or using medications for sleep apnea, I hope that pans out as well because, I do think it does. The medications do have a side effect and may be a downside for many patients, but it might avoid patients needing like the Inspire device that requires surgical instrumentation and so on. So hoping that the patients can avoid something so drastic, especially we have another option, because I do think as we're talking about this explosion of sleep is an issue, we're going to get a much more diagnosis. We can't just have 3 or 4 treatment options because I think a lot of people are going to be not tolerant to one or all 3 or all 4, and we need to have different options available to them.
Excellent. Yeah, no, that's really helpful. And just for clinicians to have that knowledge of, okay, yeah, technology has changed. The masks are smaller, the machines are smaller, they're more comfortable, and there's loads of options outside of wearing a mask if that's not for everyone. And what I tell patients too is that finding the right mask is like finding the right pair of shoes.
Mm-hmm.
You might have to try a few ones on before you find there's no one size fits all mask.
And don't feel bad if the first one isn't like the one you love, because it's like you said, you have to try it, and we have the options available now that we ever did before.
Yeah, absolutely. So, well, you've provided so much great information and I really appreciate it. So before we wrap up, is there anything else that you would like to share with the clinician community just about sleep in general, or any other pearls of wisdom?
Yeah, sure. I think, like I said, the medical baggage, when you start seeing, just ask yourself why, and then think whether this requires, and you can, if this patient seems like they have a lot of medical issues, ask the 2 questions that I talked about. Are you sleeping well? Are you waking up refreshed? And I think that's a conversation starter. Then it's for your own practice, your comfort level, whether you want to do the testing in-house or you want to refer to a sleep practice, and making sure that they have a good relationship with your patient as well to get seen. But I think triggering that, the idea is that in practice, we need to have a trigger that prompts us. We have the EHR system that does all this fantastic thing that tells us when we need to check a pap smear or a colonoscopy and so on. Unfortunately, we don't have such a trigger for sleep apnea. But one of the things to think about is if you start seeing more than one medical problem in a patient, at that point, they're not zebras. There's something that you're missing. So think about that. And we're more than happy to help. Like I said, our virtual sleep practice is in over 10 states and we're growing. We're in Texas, Virginia, Florida, Georgia, New York, Connecticut, Illinois, and Kentucky, and Alabama. and South Carolina. Anyways, but like I said, just come to our website. If you have a referral, you can drop a referral on our website itself, and we'll get in touch with the patient, get them seen. We only staff by board certified sleep physicians at this point, and we have the ability to see these patients, get them tested, get them treated, and if they need an in-lab study, we will arrange for that as well. So it's not like just because we exist virtually, we don't cover the full spectrum of care. We take ownership of the patient, just like any medical practice. When you get referred to, we want to make sure the patient's cared for. So we will do whatever it takes to make sure the patient gets their care. And what we're trying to do is make sure that they achieve the care as good as what they could have in person. That being said, I'm not trying to ever say that virtual practice is as good as in person. There will be those patients that need, but just like the home sleep test, it works for 95% of the patients, and it liberalizes, democratizes sleep access testing. And even though it has the false negative rate, it's so much better now than what it was. And we have to continuously open our minds up to those possibilities that a patient may not fit into your framework of sleep apnea or sleep issues. And if they need help, get them the help they need. Excellent. Well, thank you for the work that you're doing. Where can people find you? Just our website is www.sleep.com. It was the cheapest way for me to buy the word sleep. So it's SLIIP. So IIIP.com. And there's a referrals tab over there. Patients can book an appointment directly as well if they need to or want to. So whichever way you find best. If you refer a patient to us, we'll make sure you get the notes and get updates about what's going on with your patient, so you have full insight into your patient journey with us. Excellent. So we'll put the link on the screen here and then in the video description below. But thank you, Dr. Bhar, for joining me today. This was really wonderful. So much great information. I think this is one of those episodes that people will need to go back and rewatch again, because there was so much wisdom that you shared with us today. So thank you. Thanks. If you're a doctor who wants to uplevel your sleep medicine knowledge, go ahead and subscribe to this channel to join the community and keep learning about practical clinical sleep medicine. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine, and every video is eligible for CME credit.